Can you see my slides?
Yeah.
Yes, yes.
Yes, Abbas.
Clear.
Okay. Okay, so we start. Right. Good morning, afternoon, or evening, wherever you are in the globe. You are most welcome. Salams and greetings to all of you. I feel extremely honored and privileged to welcome you all on this fourth webinar program for the year 2023-2025. Before we start webinars, as it's always a tradition, I will just give a brief talk on the Food International Mission with Vision. Food International is a registered international non-profit association in Belgium under the Belgium law. It's a global organization consists of people working in the field of diabetes-related food complications, and all are dedicated to providing food care, prevention to the people with diabetes, and through awareness. These people are spread across the 7 regions in the world. And we are all aware that Sub-Saharan Africa, South and Central America region, Middle East and North Africa, North America and Caribbean, Southeast European region, Southeast Asia, and Western Pacific. Food International, if you look at it, it consists of board members, regional chairs, and advisory board, country representative, and the full Food International members. Our mission is to promote the global profile of diabetes food through prevention and care through awareness, guidance, education, research, and professional development, ending avoidable lower limb amputations due to diabetes worldwide. Our goal is to prevent and reduce number of unnecessary amputations from diabetes worldwide and improve the quality of their life. Our focus of action: train the healthcare workers all over the globe how to manage diabetes-related food problems effective and to prevent amputations, giving healthcare professionals strategies how to implement, develop, and sustain the food services in their countries, promote and recognition of diabetes food specialists all over the world. We should be targeting to close the gap of available and affordable diabetes food care, and especially in low and middle income countries where it is a huge problem. Our activities during these 2 years in our programs, just to share, is expected, which we have been doing. It's already past 1 year. Train the food. Flagship programs are train the food trainer courses, followed by step in each country, and World Diabetes Awareness Week, which we do every year from 7th to 14th November. We have webinars every 3 months on every Saturday, newsletters every 3 months, and these are several other projects which have been doing, which have been taken off, and some of them have already been finished. Let me just talk about flagship programs. Train the food train courses during this period. 3 of them have already been done. That's in SACA region, Western Pacific, and Europe. Europe was just recently in February. These are just to show you how this was the one which was the latest from Europe, led Slovenia, led by Velma. And then 2 others are going to hold in the month of August. Sub-Saharan Africa, that will be 11th, will be done in Zanzibar in August, and MENA region, where Zahid is going to do in the war affected countries, train the food trainer courses in Karachi, Pakistan. Then we have World Diabetes Awareness Week, where we do every year, and that's another flagship. We did it last year, and this year the dates are already out. So once near the time, we'll do the program. It's done once a year for 7 days. Brochure series are also being taken out. The fifth one was just taken out June this month. And that's the latest one, which is on the website. Anybody can download if they want to promote in the conferences. Then the newsletters, 5 of them have already been out. The latest one, which was in June, just recently, last week, it was sent to everybody. These are all the projects, the green ones, which have already been done, and over and done, and some of them are not still in the process, and some new ones have also been added, which are going to be take off this month. Then we have these webinars every Saturday, every 3 months. And today's webinar will be the fourth one. That's today, 8th of June. 3 have already occurred. And the 4 speakers you can see on your right-hand side, they have also committed. And we're going to do the last one on the 7th of June, 2025. These are all DFood International websites, and you can download all this material, education material, anything you want. Just go there and everything is free of charge. Third DFood International Conference, or 8th biannual journal assembly, would be from 9th to 11th May 2025. It will be in Malaysia, Sarawak. Today's registrations of this webinar, so for till I think 2 or 3 hours back, 12 Central European time, we looked at it, it was 378 participants from 76 countries. So that's a good number we have this for this webinar. Panelists are all board members, regional chairs, regional advisories, and sometimes we do invite guest panelists. As always, thank you to Urgo, who has always been supporting us and has also been supporting for all the activities. Thank you very much as well for this webinar. Now, before I introduce our speaker, I would like to remind for the General Assembly, which is going to be held on 22nd June 2024. This is for all the members of DFood International who have already received the notice of General Assembly to be held on 22nd June 2024, same time, 2 Central European times. All was sent agenda, attachments of several documents, and the Zoom links. Meeting will be digitally. Country representative of each country has to send the confirmation to Secretary of Office, because he is the one who's going to represent the country for voting. If country representative who cannot attend the meeting can represent by a proxy according to the current articles of associations, the new ones we have changed this system. And the proxy could be from his own country, assigned by a fellow delegate or a different country. Country representative, so far, 31 countries have not confirmed the attendance. So I would humbly and kindly request to confirm the earliest at the Secretariat office. We need to send a list to our lawyers in Belgium by next week. I think end of next week or something. If in any case you are not able to attend General Assembly, no problem, then kindly send us a signed proxy form, which we have already sent by email, suggesting you who will attend in your place, whether it's from the same country, your delegate, your fellow colleague. So we need a name of that colleague, or from different country representative, as soon as possible to the Secretariat office. I'll just give you an example. I and Mr. William have already taken a proxy for some other countries. So if you think you cannot attend, you can give, any other person can take only one proxy at a time. These are the list. We are still not getting response from Africa, 3 countries, Europe, 9 countries, MENA, 3 countries, NACA, 4 countries, SACA, 8 countries, Western Pacific 4. So total 31 countries have still not responded their attendance to this General Assembly. Here I would like to request from deep from my heart to the board members, regional chairs, regional advisories, to help us in facilitating the delegates who have still not confirmed from their region, and get a proxy to facilitate the proxy if they cannot attend this. Okay. Now I will come to to introduce our speakers today. We feel extremely honored and privileged to introduce the speaker for this fourth webinar education program. And she is very well known. Actually, she does not need any introductions. All over the world, she's known. Professor Fan Gam has been a consultant diabetologist at University Hospital for Derby and Burton NHS Foundation, UK since 2011. She is also a clinical director of R&D and Derby Clinical Trial Support Unit and honorary professor at the University of Nottingham. She is the present chair of International Working Group of Diabetic Food, which writes international consensus guideline every 4 years. The next one would be released in 27. She's been chair since this year, January 2024. She has been chair for the past both classification and wound healing subgroup of International Working Group for 2023 guidelines, and has been an editorial board of this organization for the International Working Group. Her main clinical and research interest is in diabetic foot, and she has published over 90 papers and book chapters on these subjects. She has been active research interest running several multi-center national trials in this field. She is especially interested in service development, particularly the need to manage diabetic foot disease in a more cost-effective way closer to home for patients. She's an active teacher both locally, nationally, and internationally, regularly asked to lecture at major diabetes conference. She has worked with Diabetes UK on the Putting Feet First campaign. Currently, she's leading clinical lead for National Diabetes Foot Audit of England and Wales, and has been one of the NHS England co-clinical directors of Diabetes East Midlands since May 2018, and co-chair of East Midlands Diabetic. Publications, peer-reviewed journals. She's done a number of published articles in peer-reviewed with a high impact factors, 98 of them, and high risk, high score index 40. She has been cited 5,641. She has been ranked among the top 10 specialists, and being several editors, associate editors of that, and especially just to name diabetes medicine, diabetologists, and many others. She's been awarded Edward James Holmes Award for Amputation and Prevention of American Limb Preservation Society in 2021. And now she is going to be honored for Rogers Picorer Award in 84 scientific sessions of American Diabetes Association this month, 21 to 24th, which is being held in Orlando, Florida. So we feel extremely honored and privileged to welcome our speaker, Professor Frances Graham, for the fourth webinar program. Our topic today is wound classification according to International Working Group Diabetic Foot 2023 guidelines. Before I hand over the podium to Fran, I would ask you all the questions can be posted on Q&A section, and we'll discuss later on after her talk. Welcome, Fran. I'll stop my... Yes, you can share your slides.
So now the challenge. Thank you for that kind introduction. I barely recognize myself on that. Right, with a bit of luck, I'll share the correct screen in a second. Okay, can somebody confirm that you are... No, you're seeing the wrong screen, are you?
We see the presenter.
Seeing the double screen. Big and small.
No good at all. You see, I got it right a minute ago, and then you insisted I stopped sharing. Okay, let's try sharing that one. You're now seeing the right screen, yeah?
Yeah, that is okay.
Fantastic. Okay. Let's move on, because actually I'm going to talk about other people's work and the guidelines on the classification of people with diabetes related foot ulcers, the 2023 update, because this was an update of previous guidelines on this subject that we last published these in 2019, and you'll see the members of the working group who did the work there with some very well-known names, as you can see, and some members of this society on there as well. So I chaired the group, but Matilde Monteiro Soares from Portugal was the secretary, and she actually did all the work. And in case you don't recognize those people, if you meet them in the street, that's who they are. They're smiling in these pictures, but they weren't smiling by the end of the process, because it was a lot of work. So I'm going to start by talking about why we classify at all, why we would need to classify ulcers. And that's because we all know this working in the field, but diabetic foot ulcers are not a single entity. They look different, they're in different parts of the feet, they're affected by arterial disease, by neuropathy. They have different outcomes and different management strategies. So it's actually a syndrome rather than a single entity. And so we need to group them together in some way so that we create more homogeneous groups of patients or ulcers. This way, we can ensure similar levels of care being provided to these more homogeneous groups. And how we actually do this depends on the circumstances that we're actually trying to classify. So in clinical care, we need to be able to communicate between healthcare professionals, between clinicians. So we need simple clinical descriptions, such as, it's on the toes, it's on the heel, there's ischemia, there's neuropathy, it's infected, it isn't infected. Because this way, as I'm talking to another clinician, we can gauge the urgency and perhaps a different management path that we need to go down. We also perhaps need to manage patients' expectations in clinical care. So we need some sort of scoring system in this event. We need to be able to say, this is a non-infected 4-foot ulcer, you've got good blood supply, actually with good care this should heal. They've got a really good chance of healing. Or you've got bad vascular disease, it's in a difficult place on your foot, it's deep, it's badly infected, this lesion worries me and we need to bring you in quite quickly and deal with it. So it is about communicating with patients the severity of the situation without necessarily creating anxiety for every single person. And with that in mind, it also helps us think about patient pathways. So if a patient has arterial disease and we've identified it and we've communicated, then the patient might go off to see a vascular surgeon. Neuropathy, loss of protective sensation, we would channel them down a different route, maybe to have their offloading or infection. We would perhaps speak to infectious diseases consultants. So in clinical care, there are many reasons why we would need to classify or think about the different homogeneous groups that we're dealing with. The important thing about clinical care is that you need to be able to describe every lesion every time. There's no point in saying, actually, I can't talk to you about your lesion because it falls outside my classification system, or we haven't got a classification for people who don't have any toes, for example. You need to be able to describe or classify or score every lesion every time. We could also use classification in a research setting. However, when you're doing research and if you're doing trials, you would normally describe the inclusion and exclusion criteria on an individual trial basis in a lot more detail than some of the classification systems that we have. And so it is less important that we use classification or scoring systems in a research setting. In a research setting, you don't need to be able to describe every single lesion, because if the lesion is not eligible, then you don't need to describe it. So it doesn't need to be an entirely inclusive scenario. However, it would need to be really detailed with absolute consistency and details of the descriptions. So you couldn't just say people with arterial disease. In research, you would need to describe how you measured the arterial disease, how severe it was, whether those people would be included or not. So we tend not to use our clinical classification systems in research because we need a lot more detail. My favourite, and the reason why I'm a clinical lead for the National Diabetes Foot Audit for England and Wales, is for audit or benchmarking. So we can compare against either a national standard or against other centres. This would need to be relatively simple because in clinical practice, people are very busy, so we'd need a very simple centre. And it might include an element of severity scoring so that people can't say, oh, well, my patients do badly because I get all the severe ulcers, and I'm doing really well because I get all the simple ulcers. It is about saying we're not comparing apples with pears, and so there may be an element of severity scoring. It needs to be really simple. And a good example of this was in the EuroDial study, which was published, over a decade now, where there were noted differences. This is showing you amputations, minor amputations. There were noted differences between centres in the frequency of minor amputations, but when they looked at a severity score, it correlated with severity score. It correlated very well. There were some outlying centres, but nevertheless, across the board, the main driver of outcome was the severity of the patients. And this is important because the EuroDial group could have spent a long time examining what was different in the way people were managed in different centres, when in actual fact, it was probably just the severity of the ulcers that were coming through to those centres that were deriving the outcomes. So classification or severity scoring in audit is really important, so we don't run off looking at other things that aren't important. It must be simple and memorable enough to be used in a busy clinical setting, and we're all busy. And again, it must be inclusive. So if you're doing audit, every lesion must be able to be classified or scored, and with the equipment that's available in your clinic. And then there is the thorny question of, what do we classify? Do we classify lesions, ulcers? Do we classify every ulcer on a person? Do we classify the limb, or do we classify the people? And again, it depends a little bit on why we are classifying. So in clinical care, limbs are really important for defining a pathway of care. So is the limb neuropathic, or is the limb ischemic? It would be unlikely that all ulcers on a foot, one would be ischemic and one wouldn't be. So in clinical care, we tend to classify limbs as well as lesions. In research, then that's an individual decision. We would need to take care of the analyses and make sure we're not overanalyzing 6 ulcers in one person, but it is an individual decision. And in audit, we have an indicator of severity, so we would classify limbs if it's arterial disease, but we would also classify people if, for example, a disease affects the outcomes such as renal disease. But all of these need thinking about as to what exactly you're classifying and what's the purpose of collecting those data and classifying. Now, there are many classification systems that are published, and I'm going to tell you just how many in a few slides, but the majority of them are not validated, or if they are validated, they're validated in the population from which they were derived. That means that if you're looking at outcome, then some aspects of clinical care might derive outcome. Whereas we want to know, does this scoring or classification system, is it important for every group? Can we apply it to every group across the world? And that's what we would call an external validation set. So I derive a scoring or classification system in my population. The most important thing is not what it derives, what happens in my population, but does it also work in somebody else's population in another part of the world, perhaps where ischemia is not so important, or perhaps where infection is far more important because they don't have such good treatments. And this is particularly important when what we would consider a treatment is becoming an outcome. So amputation may be a treatment, but it also may be an outcome. And often the decision about whether to amputate or not is an individual clinician one. So we would need to know if in my centre, my particular scoring system says actually with these people there's a low risk of amputation, that is the same in another centre. So we would be looking for validation of scoring or classification systems when we're looking at the quality of them. And I take you back to this slide that said, you know, minor amputation is actually a treatment, and we would need to know that whatever we did actually produced the same answer in every system that these Eurodial consortium groups were working in. So that's by way of background as to why we would even look at classification systems in people with diabetic foot ulcers. So let's take you on to what we actually did in the 2023 update. And this time, across the board, in every working group of the International Working Group, we used a much more structured approach, and this included the classification systems. So we followed the grade system. And that meant that right from the start, we asked a clinical question. And we asked, you know, what the outcomes were that we were looking at. And we clearly defined those. So, you know, we would look at healing, or are we looking at amputation? Are we looking at mortality? So we very clearly defined what outcomes we were looking for before we even went to the literature. And this is really important, that you're not then biased by what's in the literature. You set your question before you even start and decide which outcomes are really important when we're looking at the literature. And we took those outcomes and we asked stakeholders, healthcare professionals, external experts, and many of you in many parts of the world have been really important to us in the International Working Group with your opinions on our outcomes and our guidelines. So I take this opportunity to thank anybody who had input into this process. And then and only then we went to the literature to look at, you know, classifications that reported those outcomes. We then did an assessment of the quality of that publication. Did it actually report those outcomes? Were things validated? Was it done inclusively or exclusively? You know, what was the risk of bias of those? And then we would grade the overall quality of the evidence. This is a really structured approach to looking at classifications. So we did our systematic review, and then we took each classification that we found, and there were a number, and we put them through this system to look at what is the certainty of the evidence. And we used a specific risk of bias assessment. And then we did a summary of judgment. So we looked at the evidence, and we looked at how much it would cost. We looked at its equity. We looked at its feasibility in each, in every system, healthcare system in the world. And then we identified a number of classifications that we thought stood above all of the rest. So in 2019, we found 19 classifications, and we only looked at 50 studies. By doing this much more structured approach in our systematic review, we actually found 28 different classifications, and we had to look at 149 different studies to assess the quality. Now, we couldn't then recommend all 28 systems, and actually most of them were not validated, were pretty poor. We couldn't work out what they'd done. Outcomes weren't blinded, you know. I'm hearing noise in the background. Somebody mute whatever there. Maybe mute some microphone. Abbas, could somebody mute that microphone? Thank you.
Yeah, I'm gonna, yeah.
Okay, thank you. So what we really updated our methodology here. So we looked at our important outcomes, and we grouped our outcomes into clinical outcomes on the ulcer, the limb, and the person. We also looked at the usability of the classification system, the use of resources, any special equipment, and expertise. So then we, you know, took all of that back to our stakeholder group. We used the QIPS risk of bias assessment. So this is just telling you the level of detail we went to. So really justifying our choices in the end. So this was a risk of bias that we had to take through all, you know, all of those 100-odd classification systems. So it's a laborious process. And then and only then did we say, okay, we've looked at 28 different systems, but most of them are scoring really poorly on the quality of the publication that we're looking at. So we ended up with just 6 that we thought actually had some evidence behind them. And out of those, in the next process, we lost 2. So we lost the Meggitt Wagner and we lost the Diaphora. So I'm actually not going to go into any detail there, because the next stage was to say, we've got these 6 classifications. Let's go back to the start and let's think about the clinical scenarios that we're looking at. So I'm just going to just remind you of the 4 main classification systems that we actually looked at in the end in our clinical scenarios. So the first one was in infection, and this was the IDSA IWGDF infection classification. We looked at the original one. There has been an adaptation of this, which actually splits moderate into moderate soft tissue and moderate osteomyelitis. But actually, we didn't look at that because there were no validated studies. So this was the only one we looked at. Uninfected wounds, mild, moderate, and severe. Very simple and has good evidence behind it. So the IDSA IWGDF infection classification was one of our 4. The second one was the SINBAD score, which has a wealth of data behind it and is actually used in some of the international audits now. Simple score, well validated internally and externally, scored reasonably well on the risk of bias assessments. Very simple 6-point score, 0 or 1. You can use it in its individual terms, so you can use it for communication, a site ischemia neuropathy. You can describe an ulcer very well with it, but you can also use a severity score of 3 or more for a severe ulcer. And then the Wi-Fi score, the reason why I've put these on the same page is to show you the difference in complexity. So the SINBAD score is very simple. The Wi-Fi score, which was actually derived in for PAD with wounds, not necessarily in a diabetes-related population. The Wi-Fi score is a lot more complex. It includes the IDSA, IWGDF classification here. So part of that is actually the IWGDF, IDSA infection classification. It describes the wound, depth, the ischemia, and the infection. And then you put that into an algorithm, which gives you a class of amputation. So whether that's high or low. And there is now an app you can use which tells you this. The actual levels of risk of amputation were actually derived not from clinical data, but were actually a Delphi consensus by the American Society of Vascular Surgery. So when it says high and very high, it's not quite as high in other countries as perhaps in the USA. Nevertheless, there are many studies validating this, many of them in a mixed population, and not all of them pulled those with diabetes out. So actually the validation in people with diabetes is less than in the total ischemia population. Nevertheless, it's widely used and well defined. Wagner, I'm just reminding you, is really clumsy. It doesn't pull things out separately, and most of our ulcers fall into 1 or 2 with perhaps a few 3s, but you can't define infection and vascular separately. So we didn't actually, even though it was well validated, we didn't recommend it. And then the University of Texas, we didn't recommend because we didn't feel it had anything to add above and beyond Wi-Fi. And the Diaphora I'm not putting up there at all, is just one study, and it's quite complex. So that's the UT, University of Texas, which I think has been superseded by Wi-Fi now. Out of interest, neither the Wi-Fi nor the University of Texas includes neuropathy. So if your clinical practice is that all those with neuropathy get offloaded, then you don't get neuropathy in either Wi-Fi or UT. So it is missing a component there. So having done all of that, and we took this is extremely busy, but we took ours just again to show, the detail of what we did. We looked at our summary of judgments with all of these. We looked at the equity, because some of these classifications require equipment, the acceptability to stakeholders, the feasibility. We said probably no in every country of the world because of the detail required in Wi-Fi and the costs that were reported. So it was a very detailed summary. And then, having done all of that and defined in some detail our top 4 to 6 classification systems, we then went back and said, okay, we've got our 5 scenarios. Which of these classification systems best fits with these scenarios, on the basis that no one classification system will fulfill all of these different scenarios. So for communication, as we've already said, it needs to be inclusive. It needs to include all the things that we need to talk to our colleagues about. So we need to be able to classify every lesion and have the equipment to do that. For predicting the outcome of an ulcer, so to be able to say to a person, you have 90% chance of healing over the next 3 months, or you have a 1 in 3 chance of having a major amputation. Really important to patients. We need to be able to characterize a person with an infected ulcer, because that pathway of care is different. We need to be able to characterize a person with peripheral arterial disease, where you have access to vascular surgeons and vascular surgery. And we need to be able to audit and benchmark. If we're doing that, it needs to be a very simple classification, it needs to be inclusive, as we've already said, it needs to be something that you can remember easily and can be easily done in a busy clinical practice. So looking at those classifications, we then said, which of our classification systems are we actually going to recommend? So in previous iterations of the guidelines, we said that you should use the SINBAD system for communication, simple, quick, 6-point scale. In 2023, we went that little bit further because we had more data to look at on the Wi-Fi system. And we said, actually, use the SINBAD system, but if you have the appropriate level of expertise, if you have the resources and the equipment, then you can consider using the Wi-Fi system for communication with healthcare professionals, because it will help you define how quickly somebody needs to be seen, and a vascular surgeon will still want to know what the vascular status is. But remember that the Wi-Fi system does not include neuropathy. And remember that when you're using this for communication, you have to use the individual variables. You can't just say, I've got somebody, with a Wi-Fi grade, whatever. You need to be able to define individually so that they know what you're talking about. There's a spelling mistake on this slide. Sorry about that. Recommendations for infection. To classify a person with an infected foot ulcer, we suggest using the IDSA IWGDF 2015 version. We've also said, actually, as the Wi-Fi includes the IWGDF IDSA system, then you can use the Wi-Fi because it already includes it if you've got the equipment and the resources. However, when it comes to classifying people with peripheral arterial disease, the only one we would recommend is the Wi-Fi, which is a way of stratifying the likelihood of healing and amputation. For audit and benchmarking, again, we haven't changed our recommendation because the SINBAD is the only one that is simple enough to allow regional, national and international audits where everybody can have the equipment, and it's simple to use, and that hasn't changed since 2019. You will note that I've missed one out, and that is because at the moment, none of these systems is good enough to say to somebody, you have an absolute risk of this, of an amputation or healing. We can say these ulcers are associated with a better outcome. These kind of ulcers tend to get slightly worse, but that absolute prediction is simply not there. And this is some work that Mathilde did some years ago, where she compared all of these. This is actually minor amputations. No, this is major amputations. And she took all of these classification systems, put them through the patients in her clinic, and looked at the sensitivity and specificity. And you'll see that the majority of them are very poor at actually predicting major amputation. So it would be really difficult to say to somebody, you know, you have a high risk with any certainty. So none of them are particularly good at that. And this again is data from the Wi-Fi, just to exemplify this. This is just one of the many studies. This is all patients, not necessarily those with diabetes. And these looked at the amputation rates, even those people with stage 4. This is it's a meta-analysis of a number of studies, and you'll see that the major amputation rates, even in those that are graded as being at high risk of amputation, if you use that algorithm, somewhere between 6% and 64%. Now, in every case, there is an increasing risk of amputation as you go across. But if you just took a patient in stage 4, you wouldn't be able to say to them, you know, you have a 90% chance of major amputation. You'd say actually somewhere between 6% and 64%, higher than the other people, but not necessarily good enough for individual prognosis. And we don't know which 20% of those people. So at the moment, none of them are good enough for prognosis. And this again just exemplifies the same thing, that there wasn't a lot of difference between clinical stage 2 and 3 in this particular study looking at Wi-Fi and freedom from amputation. So we think that in the future, we will be looking at artificial intelligence to actually better predict the outcome of an ulcer. So at the moment, none of them are good enough for that, but we have scenarios for communication, for characterizing infection, for peripheral arterial disease, and audit and benchmarking. All of the 28 systems showed low certainty of evidence, so please don't invent any more systems. We'd be very grateful if you were doing some research, that you would do research on validation and optimization of the existing systems, particularly those top 5 or 6. And if anybody is particularly keen on prognosis of individual outcomes, then we are thinking about artificial intelligence, because I think there's an awful lot more that needs to be done in that area. So with that, I will thank you for your attention and thank those that actually did all of the work, and stop sharing so we can take some questions.
Thank you very much, Fran. That was fantastic, to the point, and very clear as usual. Thank you very much. Before I start rolling the ball, I have 2 questions, but I would share that I have a couple of manuscript with Fran, and one of them, which we did it in 10-12 years ago, was Sinbad. Very privileged to be part of that. That was initially we did 4 or 5 centers. Yeah.
So yeah, thank you for your data there, Abbas, because that enabled us to do a validation in your country, and that's the sort of really useful work that we need to do with these systems. So thank you for your patient data. That was really useful.
Welcome. Thank you. So I have 2 things to ask, mostly related to low and middle income countries. There's number 1 is, why are no system being recommended for research? And 2, which I always been asking, it would be nice to hear from you. Why do what we do if we don't have any equipment to measure ABI or toe pressure?
So we don't recommend systems for research because actually every research project is different. You know, you should be defining, you know, in advance the patients that you want in your research project. And it might fall outside a classification system. You can use the sort of, you know, components of it. So, you know, the Wi-Fi system gives you very nicely, lays out what, you know, what normal, what high, you know, extreme arterial diseases. It defines that very nicely. But you might not want to use those patients in your research project. So that's why you should be just sitting down deciding the patients you want in your research project. There's no need to classify them at all. Your fingers are probably the best measure of arterial disease where you don't have equipment. And that is the problem with, you know, both the University of Texas, which actually defines arterial disease with toe pressures and ABPIs, and Wi-Fi, is it is very reliant on equipment. And I once said to Joe Mills, well, what do you do if you don't have the equipment? That I asked him that question on your behalf, Abbas, and he said, well, you feel pulses. And I thought, well, if that's the case, why don't you just put that in? Because Sinbad is just feel pulses. And I think, you know, you can't go wrong with feeling pulses. And if you don't have a vascular surgeon who's going to address these issues, then feeling the pulses is probably the best way of dealing with that. If you have the money for one tiny piece of equipment above and beyond your fingers, I would say a Doppler waveform without the cuffs and without the toe pressure, because if you can hear bi or triphasic pulses, it is extremely unlikely that person has vascular disease. But otherwise, fingers are the best equipment.
Thank you very much, friend. That's fantastic. Very nice. Yes, Vijay, you have a hand up.
Yeah, Fran, it was nice working under you in the wound healing group. You were very strict. That should have been told that she was very strict and she made us work on Sundays too. Now the question is, Fran, if you have everyone with neuropathy, with lots of protective sensation, as in India, can you still use the UT? You said the UT is not good because neuropathy or lack of sensation is protective sensation is not there. But we find in India, everybody has got lots of protective sensation. Everybody with diabetes who develops a foot ulcer has a foot neuropathy. So would you still recommend the UT?
So we didn't having, you know, you've got two systems, you've got UT and you've got Wi-Fi, and actually Wi-Fi is better validated and probably more accurate than UT. There's a little bit of uncertainty around the validation of the UT. So if you had to choose one or the other without neuropathy, I would say go for Wi-Fi. It's got a lot more data behind it. It's a lot better laid out. So if you're going to choose a system and you're saying everybody has neuropathy, then of the two, use Wi-Fi. What I would say is that, Vijay, your population may change. And I think this was the situation maybe 20 years ago in the UK, was that everybody with a diabetic foot ulcer had neuropathy. But we're seeing things change now. And we're seeing far more people with neuroischemia and now pure ischemia with diabetes. And so the population changes. And using a system, you know, for audit and benchmarking and that sort of long-term view, such as Sinbad, allows you to see that. And I can see that through the National Diabetes Foot Audit. I can see the population of the UK changing with their diabetic foot ulcers, because we've done 10 years of audit on people coming to foot clinics. So it allows you to actually see things across a time scale. And it would be really interesting to see what happens in India over the next 10 years, whether you follow that pathway that's happening in the UK with fewer people having neuropathy, and they're getting older in the UK as well. older and older.
Okay, so we'll take from Q&A. There was a question from Kenya, Dr. Shipla. I think that is about ABI. I think you have already replied that regarding if we don't have any equipments. Then there is for practical purpose, how would you write down on a discharge letter or a referral letter the diagnosis of an ulcer with Wi-Fi system, something like W grade 2, 1 grade 3, or FL grade 2?
Yeah, you would so that would be on a discharge summary. It's a really good question because that's for communicating with another healthcare professional. So that goes to, I want to communicate with the healthcare professional. So then you would use those individual components of the infection, ischemia, and wound as laid out. You would have to use those individual components. You wouldn't say an overall severity grade because that's about looking at the risk of amputation. So it's really important to say, I took you right back to the beginning as to why you would need to classify. So I would say a discharge summary is communication. So go back to the individual components.
Yeah, another question is from Nozifo. Can the reason for a poor outcome on each system be related to what type of treatment provided for these ulcers?
Absolutely. Although we did see from the Eurodial that actually when they took the severity into account, there were some outliers, but the majority of them fell in the middle. And so it was, it was severity in an outcome. And I think that's really important. And that's what we do in the National Diabetes Foot Audit of England and Wales, is we look at the outliers. So we look at the severity scoring, and then we look at the outliers. And then we say, well, the outliers, the good outliers, as well as the bad outliers. So we'll say, what are the people in the good outlying centres doing that makes them so good? And can we spread that to the rest of the country? So you're absolutely right. The outcomes are treatments. But actually, unless you look at the classification of severity, then you can think, oh, they're doing really well, and they're not necessarily doing really well. So yes, the treatments are really important, but we only know that if we've audited and looked at against other centres.
Yeah, I think the next one you have touched it, but I'm going to read. How do the health workers choose the best fitted classifications for diabetic foot ulcer? Is there any algorithm available which is useful to choose the best classification?
So I would go to the International Working Group guidelines and read the guidelines in full and decide what scenario you are in, and then pick the one below. So there isn't an algorithm. There are those particular scenarios.
Yes.
I've obviously skimmed over it, but if you look at the guidelines document on www.IWGDFguidelines.org, freely available, you can see the full guidelines and the rationale behind that decision making. And for each scenario, it lays that out. So I would go to the guidelines and have a look. The slides are there as well. And there's actually, I think Matilda's recorded a lecture. So there's lots of material for you to go to. But the first thing is to decide what you're classifying for.
Thank you, Sam. Yeah, Milan, your hand is up. We come back to panelists.
Thank you, Madam. A very nice, informative lecture, and your views on the classification of diabetic foot. As Dr. Vijay said, we have a lot of neuropathic patients in India, and when we consider neuropathy as a factor to be taken into the classification, we only see whether the sensations are present or absent. What is your view about including deformity, which is almost present in most of the 90% patients that I see in a medical college in India, a deformity to be taken as a factor during classification of diabetic foot? Your views on it?
Really interesting question, and my question would be, then we need to look at whether that is a useful addition, whether that actually improves the accuracy of the classification system, because we can keep adding and adding and adding, but actually if it doesn't move that sensitivity curve any further up to the top left, then it doesn't help. And the problem with deformity is that it's really hard to define. You know, what is deformity? So deformity actually appears in the UK in the risk assessment for the development of an ulcer, but it doesn't sit in SINBAD because it's really difficult to define. And it's the one thing that it is really badly done in the risk assessment for the development of an ulcer. So by, you know, I think if you think it's important in your system, then look at it. Take your data, apply, you know, the classifications, see, you know, add deformity in there, but you will have to define what you mean by deformity, and that is really difficult. In the UK, we define it as the person can't put on a pair of high street shoes, you know, without a, you know, a rub somewhere on the top. But that's not a scientific description at all. So, and how bad is the deformity? You see the problems, and then you've got to check that, you know, when I say it's deformed, you also say deformed. What's the inter-rater reliability? You know, if you say it's deformed today, is it still deformed tomorrow? There are each individual component of these classification systems has to earn its, you know, has to earn its right to be there and make a big difference, or you're just collecting data for the sake of collecting data. But Milind, I'd be glad to discuss with you, you know, a future project on this.
Yeah, right. Because it definitely affects the outcome. Presence and absence of deformity will definitely affect the outcome in a diabetic foot patient. This has also been described in the NICE guidelines, newer guidelines. So I thought I would have your view on this, and we will definitely discuss in the future. Thank you.
Thank you.
Thank you, Sam. Okay, something to do what you just mentioned about. What about wounds associated with bone deformity as a part of classification?
And I think that's the same question, isn't it?
Yes.
You know, define. Now, those who, you know, those who are talking to you on the offloading guideline would say that if your offloading was good enough, you should be able to manage that. You know, and that the neuropathy in itself is actually the major feature, because you would definitely need to offload. But I think it's the same thing, you know, how much deformity, where, you know, can you actually define it? And if we can, and it actually earns its place in a classification, then fine. As we said, you know, the most important thing is that we don't keep inventing new ones. We actually refine existing classifications. But deformity, if everybody can define it, if you can measure it, if it's the same every time, and it actually makes a big difference to accuracy, then, you know, then it should be looked at. But we need to do the work first, and then publish it, in an external validated set. And then in 2027, we'll look at it again.
Yes, thank you. Yes, Zaid, your hand is up.
Yeah, thank you very much for a wonderful lecture, as always. I'm just have a small query regarding the use of classification at the primary care level, and what will be a good classification for their use as a referral policy as well.
Sorry, I didn't quite catch that, Zaid.
As a referral policy.
Yeah.
For referring the patient as well.
Yeah. So that's where communication is really important. So this again just comes back to, you know, which of the categories does this fit into? So communication. And so in a primary care level where you haven't got any equipment, then there's nothing wrong with SINBAD. That's the one we would recommend, because it covers all of the important items: where it is it ischemic, is it infected, has the patient got neuropathy? You know, it covers the main things, and you can then use that as your referral policy. You can define which of those things you want to see in your service. So that's communication, SINBAD, if you've got the equipment, which you probably don't in primary care. If you've got the equipment, then second line would be Wi-Fi.
Okay, thank you.
Thank you very much.
There's another question. If a patient came with a mixed infected and ischemic foot ulcers, which one we choose first to do? Revascularization or debridement?
Oh, we're straying off classification into management. It depends how severe their ischemia was. If they've got ischemia, severe ischemia, then you probably wouldn't want to debride them until you'd managed that. Some vascular surgeons revascularize first and debride later. Some debride first and revascularize. It depends on the severity of the ischemia. So I can't answer that. It depends on your local guidelines.
SIMBA classification can include 3D: deformity, duration, double ulcer, for better understanding of diabetic foot ulcer.
Interesting, yeah. So actually, we are currently in the so the deformity comes back. Duration isn't in SINBAD at the moment, but we do know it's a poor prognostic sign if somebody's had an ulcer for more than 6 months. They're in a poor prognosis there. We haven't added it yet, but we are looking at multiple ulcers through the data in the National Diabetes Foot Audit to see if actually the addition of multiple ulcers actually improves the accuracy. And it would be one simple thing, you know, is this person's first ulcer? So, you know, we're calling this SINBAD 2, but it's not validated yet, but we've got 160,000 ulcers now in the National Diabetes Foot Audit, so we should be able to get some data on that relatively soon.
Thank you, Sam. Yes, Professor Sharkawi, your hand is up.
Yes, thank you very much, Professor, for the wonderful lecture. Really, everyone enjoyed it much. I want just to add a point about the question of if there is ischemia and infection, because I'm a vascular surgeon. Usually, ischemia does not coincide with infection. Rarely it comes, because when there is ischemia, inflammation is not that evident. But the problem is when there is ischemia and minimal infection, we have to recognize that. When we revascularize, we have to do debridement on site. If missed, this infection will lead to severe fulminant infection and maybe toxemia, and the patient may be in the ICU and may be forced for amputation with palpable pulses in the foot. So it's not the problem of ischemia and infection in the initial management. It's, of course, ischemia have to be corrected. Then the infection, if it is usually it is very minimal, it have to be debrided, not to make a catastrophic change for the patient. I think that.
And this is the problem with these clinical classifications of infection. You're absolutely right. They rely on erythema, inflammation, edema, and if a person has severe ischemia, they might not be present. So, you know, we always have to bear in mind that if the person doesn't fit the classification, you know, the classification may be underestimating the severity of the situation. I absolutely agree with you. You know, these shouldn't take away from our own clinical expertise. I totally agree with you, but we have to do something, and we've, you know, it at least allows people to look and think and not use, you know, their own impression when they're not experts in the field. But thank you for that comment. You're absolutely right. With severe ischemia, the signs of infection may be masked.
Yes, thank you.
Thank you, Sam. Yes, Zaid, your hand is up. Okay.
Yeah, the other point regarding the classification, the CKD is one of the factors which may affect the prognosis. So does any of these, not including this classification, not including the CKD or the CCF in this one? So you think that might help in future?
Yeah, and again, it's something that we can look at. I think in terms of individual prognosis, because we're now straying into the, you know, the individual prognosis scenario, and there is actually a question on there about PAD neuropathy, the score of SINBAD is equal. I've just seen that. You know, we're straying into the individual. You know, I've got a patient in front of me with all of these different things, and I need to be able to say to them, you know, you've got a good chance of healing or a bad chance. And the problem is that none of them are good enough. And that includes, you know, those people. It's actually, it's dialysis is the biggest, renal replacement therapy is the biggest risk factor, which interestingly in the National Diabetes Foot Audit is a very high risk factor for amputation, but comes lower down the list in terms of healing. It comes way below everything else. So in terms of healing, renal replacement therapy, it doesn't have that much of an input, but in terms of amputation, it does. And so these individual prognostic decisions, I think we need a bit more sophistication. You know, when you think about, you know, Q risk scores for people having heart disease in the next 10 years and whether they should have a statin or not, and the risks for anticoagulation with atrial fibrillation. And we've got, you know, algorithms, the Framingham study and the Framingham equation, you know, they're a lot more sophisticated than those that we're using. So I think the future is going to be really interesting in terms of putting all of these different patient and limb variables and trying to develop an algorithm that would actually predict outcome, but we just don't have that yet.
Thank you, Fem.
Thank you. Thank you.
I found Roberto, you wanted to ask something? I found your hand was up.
No, thanks. I opened my connection with the video today now, and I click on my hand, but there's no problem. It's very interesting. Very interesting. One thing, it's a very interesting discussion talk. My question is why also now when we classify diabetes lesion is so difficult to have all organization that put the Wi-Fi, for example, as a universal way to classify an ulcer.
Why can't we just say use Wi-Fi for everybody? Was that the question?
Now the question is that generally when we see a classifier of ulcer, generally use Texas classification. It's really difficult to have a homogeneous way to classify.
Yeah.
And that's the problem when we want to put together some outcome, some results of our actions. I'd like to have your comment about this.
Yeah, and sometimes it requires to be done at a national or regional level. And so it was decided by NHS England that SINBAD would be used as the audit benchmarking tool when they looked at all the available options. And so now every diabetic foot clinic uses SINBAD and submits their data to the National Diabetes Audit. But we do have a National Health Service in the UK, so it's a lot easier for somebody at national level to say, this is what you're doing, and you're all doing it, and you're all doing it the same way, and then we can look at data on a national level. It requires somebody to actually make that decision to say, this is what we're going to do. Otherwise, and it was the case 10 years ago in the UK, some people are using UT, some people are using Wi-Fi, some people are using nothing. They're just taking a picture and describing it. So it is a national decision really, but maybe as DFOT and you know, national representatives, this is the sort of conversation we can be having with our decision makers.
Okay, thank you. There's one or two more questions in the question box. If you have a multiple ulcers, which one to choose for SINBAD classification?
So in the National Diabetes Foot Audit, so if you're doing it for audit, we choose the biggest or the most complex. So the one that scores the highest, so that's the worst outcome, goes into the National Diabetes Foot Audit because we count people in the National Diabetes Foot Audit. So if for audit, you would use the worst. You always pick the worst case scenario. But if you were describing the ulcers in communication, again, it goes back to think about the scenario that you want to do. So for communication, if somebody had more than one ulcer, then each one would be described. You know, ulcer 1 is on the toe. They're obviously, you know, ischemia is the limb. You know, it's a neuropathic ischemic, but ulcer 1 is on the toe, so it's a forefoot. Ulcer 2 is on the heel, so it's a hind foot. So for each ulcer for communication, you would classify. For an audit, you would classify the worst.
Okay. If we have a PAD or a neuropathy, the score of SINBAD is equal. And you have been asked, isn't it? What is your interpretation for this issue?
So it's not equal. So ischemia, it is in the SINBAD score. I agree. Because it's simple, it's an audit tool, it needs to, you know, it's yes or no. But actually, in terms of prognosis, and it goes back to what are you doing this for? In prognosis, then ischemia is worse than neuropathy. Neuropathy comes out at about 5, I think, in terms of our list of prognostic outcomes after ischemia, area, depth, time to first expert assessment, infection, and neuropathy is our 5th most important in the National Diabetes Foot Audit. So ischemia dominates everything, but that's for prognosis, and we don't have the tools for prognosis yet. So I agree. If I was talking to a patient, then their ischemia would be more important than their neuropathy in terms of their outcome, but they're both equally important in terms of the way that I would manage them.
Thank you. And maybe lastly, somebody has asked, needs more elaboration on concerning the auditing and benchmarking. What was that when you mentioned about it?
So this is so I'm not sure what you mean by elaboration concerning an audit and benchmark, whether you mean, you know, why we would do audit and benchmarking. That's just to compare our practice, other centres and other people internationally, so we can all learn from each other. And I think the beauty of doing it within the UK, within the National Health Service, is that, you know, we're not necessarily looking at those people that are doing badly. We look at those that are doing really well and say, what are you doing that we can learn from? So it's a way of you know, comparing ourselves with our peers so that we can learn from the best, and everybody does the best for their patients. But if you want a little bit more detail on the decision making for audit and benchmarking and the classification, it's all laid out in a lot more detail in the guidelines document, which, as I say, are freely downloadable. Just go and have a look, and there's, you know, slides and lectures. I think there's a podcast on classification you can tap into as well. It'll send you to sleep. It's a nighttime podcast. It'll send you to sleep in 5 minutes, but it's there.
Then you can see how interactive it is, how people are interested. So that means everybody was awake when you gave a lecture.
Stayed awake.
Yeah, and you can even see the panelists, all of them are also awake. And there are some questions I've left because time is not in our favor. So I had to select some question. So It was really fantastic, one of the best webinar we had. Thank you very much. Now I'll hand over to my elect president to give vote of thanks. Yes, Harry, Professor Harry.
Yeah, but I think firstly, Fran, it's been wonderful. And I think Professor Game has given a superb lecture basically on classification. And I find that is actually the problem. Even in Malaysia, we have the same thing also, because some of our classifications are still using UT. So at least what you call is with SIMBAD and Wi-Fi is much more better. At the same time, I think I would like to thank Dr. Abbas and the whole team, Ali and the Secretariat, and then our regional chairs, advisors, and also the regional members of the council, as well as all the delegates, not forgetting basically Ergo Medical, our largest sponsor, and everyone for this wonderful session. And I will take Fran up on her idea to go and look at the podcast later in the evening to see whether it'll knock me off or not. So with that, what do you call this? Thank you again. I think it's wonderful, and we hope to call you more often, friend, for more sessions.
Absolutely, feel free.
Wonderful, thank you.
He never refuses. Thank you very much. Thank you very much, friend. And lastly, I would say that the next webinar is on 7th of September. Mark your diary. It's by Professor Ketan, who was also involved in international consensus in wound healing intervention. So thank you very much for attending this. Thank you. Thank you, Fran. Thank you.
Thank you very much, Frank.
Welcome.
Wonderful
Take care. Have a
talk.
good weekend.
Good
Thank
to see you.
Thank
And
you.
you. Bye.
Have a nice weekend.
Thank you very much. Very
Thank you.
beautiful talk.
Thank you.
Bye bye.
Yeah.
Thank you all, Vilma,
Bye.